I'm so happy to be here with all of you, and those of you who are here in the afternoon today, welcome. I'd like to talk about my disclosure first as we go on here. Here we go. Is there a green one? Okay, there we go. So my disclosure is that I'm the principal of Donna Consulting, LLC. This is the 28th year for my business. I'm a professional certified coach specializing in physician coaching. And as Ken said, I think I'm the only one in this entire facility, not just the people in this room, who's not an MD, as I look through the brochure. However, I spend 98.8% of my time working one-on-one with physicians or with groups of physicians in group practices. And conflict management is certainly one of the things that I work with all the time with physicians. So I'm here to share with you what I know about that. I also want to say that the speakers previously all dealt with issues that people have conflict about. It might be personal conflict, or it might be conflict with somebody else in the workplace. But they're dealing with whether it's work-life balance or professionalism, disruptive behavior, et cetera, et cetera. So one of the things about conflict that always amazes me, you hear people talk about it, you read about it, and people say, oh my God, I don't want to be with that group of people. There's conflict all the time. The mic is not with me? Okay, great, thank you. So am I okay now?
I think so.
Okay. Can the people in the back hear all right? When I was sitting in the back for something else, it was hard to hear some of the speakers earlier today. So one of the things I want to emphasize, that conflict is a probable and often necessary ingredient when any two individuals are together or whenever there's a group of people together. So conflict is not a negative word, but the kind of conflict that somebody's engaged in is the important piece here. So there are two kinds of conflict. One of them is constructive conflict, and the other is destructive conflict. So let me talk first about destructive conflict, and I think that's what people always have in mind, or usually have in mind when they think about conflict. We all know about destructive conflict when someone is harmed either emotionally or physically. Previous speaker, I think, talked about charts being thrown occasionally, or even somebody going over and tapping somebody on the shoulder a little bit too hard, and that person feels like they've been hurt. And that would be destructive conflict. Emotional conflict people sometimes aren't aware of. I think that physician educators and even residents or medical students aren't aware that what they've said to the other person, often alone or even in the company of other people, is emotionally damaging. And I want to say one other thing about disruptive conflict, that you're all in the business of positive and quality patient care. And important thing to think about is when somebody is harmed emotionally and or physically in the process of a meeting or in the process of an operation, in the process of whatever, that person is upset. And ultimately, that upset, that emotional upset, can harm a patient. I've been in the situation where I'll be in a hospital and I'll see that often it's more of a woman who will go to the ladies' room, and I'll find her crying in the ladies' room because maybe the attending said something to her in front of other people that she found insulting or embarrassing. And I don't know that that attending ever realized what he had said or she had said to this person that made that person feel that bad. So part of it is we're going to be dealing today is how do you deal with destructive conflict, but we're also going to deal with how do we deal with, can't get myself back here. No, I want to get back to constructive conflict. There we are, constructive, thank you. Constructive conflict, if you look at the faces on these people, you can see that perhaps the one with his back to the others is a resident or a medical student, or it could be another attendant. And the other two doctors are concerned, you can see that. But they're engaged in a conversation that appears to be respectful. Hopefully the words that are coming out of their mouth are respectful. The one certainly to the right in the picture seems to be a little bit calmer about it. The one in the middle is serious and firm, but hopefully respectful. And in constructive conflict, we want to know that individuals are respectful, and that the other person can hear what you're saying. If you're not respectful and you're destructive, the other person cannot hear what you're saying. There are words coming, but they're not really hearing them. So when we look at the conflict, we have to think about what are the causes of conflict. Some of them are, and I've heard some of it today already by the previous part of this panel, that the causes of conflict in your organization might be some things that you can't do anything about. Number one, of course, insurance companies and the way that they handle things in terms of hospitals and payments and so forth. The big one that I hear about all the time now is electronic medical records. I've worked in a number of hospitals where they're involved in Epic. And my goodness, the tension and the stress that's going on as people are converting from one system to the other creates so much stress that people are ready for conflict any second, any minute, if someone talks to them the wrong way. Other causes, I'm sure you can think of many of them. Productivity. I don't know if you've had to deal with this, but I had a surgeon not too long ago who told me that they were told that they have to go faster. That productivity, get the patient in, get the patient out, and here's the number of patients you have to operate on today, and it has to be faster. And the surgeon said, it's not my fault, the nurses aren't coming and doing what I need them to do. They don't get the patient into the room fast enough. And so then the patient goes to the nurse manager, and the doctor goes to the patient, the nurse manager, and tries to talk about, you need to get the patients in there faster. And not, all of a sudden they're involved in a major, major conflict where sometimes they're calling each other names that they shouldn't call each other. And sometimes, and it happens more often than not, I'm finding that nurses and techs and others are reporting a physician for what they would call inappropriate and unprofessional behavior, as we heard about lots of those things. More and more, and they're being told by their chairman of their department or of their supervisors, you report anybody, including the doctor who's the surgeon that you think so much of, but he or she has treated you disrespectfully. Report them. So it's really, really important that you understand the causes of conflict in your organization, but understand where you fit in with that, and is there anything you can do about it? Can you talk about it in your group meetings? Can you bring it to your supervisor? What can you do? And certainly, those of you who are educators should help the people that you're educating understand what their roles, responsibilities, and rights are when they're not treated appropriately, whether it's a conflict situation or not. Aside from the organization and those conflicts, we also have your own personal triggers. And we all have triggers, I guarantee you. I have triggers, you have triggers. Lack of sleep is a big one. If you've been working 3 nights in a row, you've been on call, and then you've been in the office the next day, or you've been operating on patients the next day, and you're exhausted. I had somebody recently tell me that one of the people in his department, this is a surgeon, one of the people in his department had left the hospital, and so he was asked to double up on all the cases. And he said he'd been on call day and night for 7 days and had very little sleep. Well, of course, he's going to be triggered for all kinds of things, let alone conflict. Another one is a medical error. Perhaps you fear that you've made a medical error. Perhaps you know you've made a medical error. Perhaps you know somebody else has made a medical error. Or another one is, suppose you see a patient that you think someone else has made a medical error and you're triggered. And in terms of ethics that we heard about a few minutes ago, not too long ago had a client who told me that he knew that somebody else had made an ethical error with a patient, and he was scared. He wanted to report it, but he was afraid of the conflict situation and what would happen between him and the doctor who he thought had made that medical error, and he didn't know what to do, and he called me up in an emergency and said, I'm frightened. Ethically, I need to report it, but do I report it? Should I report it? And the next one is stress, and all that we heard about work-life balance. Everyone's stressed today. I don't know the answer to this. But by the way, there is a good book called Work-Life Balance in a Medical Life. I can't remember the author. This fellow died a few years ago. I don't think it was from overwork, but he wrote a very thorough book about this. But when one is under stress, there's so much of a chance that you're not going to be able to control and manage yourself in conflict situations. And I'm going to tell you about ways to manage yourself, but it's going to be much harder when you are in that situation. So number one, I'm going to recommend that you have on your computer or in a notebook or something that you list what are your personal triggers. I find that surgeons, really bright, competent, capable surgeons, have a trigger of when they find somebody that they're working with, a resident or a medical student in particular, who is not as doesn't have as high standards as they have. So if they want, let's say, a student to go, a medical student or a resident to prepare for surgery the night before and look it all over, understand the case thoroughly, and then they come to this OR and they don't know what they're going to be doing that day, the surgeon will tell me, I can't understand it. I can't believe this person didn't know that's what you're supposed to do. And all of a sudden it blows up into a major conflict situation where the surgeon is insulting the resident or the medical student or even a peer in front of other people. That person is all upset, and now we're at risk for harming the patient because we have somebody in training who is upset emotionally and embarrassed, and that's a big thing that's going to cause a lot of problems for the patient. So make sure that you are aware of your own triggers. And I say write them down. Don't just say them in your head. Write them down, whether you're the educator or you're the student, in quotes. Make sure you write down what are your own specific triggers. We all have them. I have them. And have to learn how to manage those triggers. But your behavior breeds the other's behavior. A big quote, and I say this to people all the time, remember, behavior breeds behavior. And we know, if you think about if you've ever made a telephone call to let's say Comcast or something like that. This morning I heard my husband early this morning on the phone with Comcast, and the next thing I know, I heard my husband's voice getting louder and louder. All of a sudden, his voice got softer. And I couldn't help but I asked him afterwards, how come all of a sudden when you were escalating, you got softer? He said, because the person on the other end of the phone got softer when I got louder. And I said, oh, that person's behavior affected your behavior. If she, and I think it was a she, got louder and louder, then you would get louder and louder, and now you've escalated into a conflict that's going nowhere and helping no one. So remember, behavior breeds behavior. And especially, someone said earlier today, too, in the panel, be a role model. Be a role model for good behavior and good professionalism when you're working with other people. Well, here is something that I really highly respect, and this is from the Thomas Gilman Conflict Mode Instrument. It's the 5 conflict management handling modes. And I'm going to briefly go over this, but I would recommend, and by the way, I checked and said, I hope this isn't damaging my disclosure of anything. I have no financial relationship with the people who designed and developed and published this survey. But I think it's a really valuable survey. You can purchase it at minimal cost, and you can take the survey, and it will help you identify what's your natural conflict management style. So I'm going to go over these 5 real quickly. Competing. Competing means, by the way, every one of these is useful, valuable, and has the right time and place to use it. Each of us has at least 1 or 2 preferences, and that's what the survey does, let you know whether you're more of a competitor or an accommodator or what you are. The competitor says, I want A, and the person I'm in conflict with wants B. Does A win or B win? One of them's going to win. That's conflict. Avoidance, compete. Avoidance is an easy one. That's I want A, you want B. This isn't a good time maybe for us to talk about this. Or maybe I have experience with you over and over and I know I can't change your mind. Or maybe it just isn't the right time now because we're with a whole group of people. We're in the OR and everybody's watching, or we're in a class and everyone's watching. So I'm going to put this aside for now, maybe forever, or maybe we'll get to it later. That's avoiding. And there are some of us who are avoiders. We do that all the time. Accommodating is very similar to compromising. Compromising, though, says, I want A and you want B, and we're going to take a little bit of mine and a little bit of yours, and it's going to be AB or BA, one or the other. So I haven't let go of everything I believe and think, but we've put it together. Accommodate says, I want A and you want B, and I'm going to give in to you this time. It's not such a big deal. I think of this of anesthesiologist and surgeon. And I had an anesthesiologist years ago who just absolutely hated working with surgeon X. And surgeon X, whenever he would say to this anesthesiologist who was young, you must do the following with my patient, the anesthesiologist would say, I don't agree with that. That's not a thing that I would ever do. I've learned that that's not a good thing to do. And the surgeon says, you do it. I'm in charge, and this is my patient. And that would be a compete situation, and my client says to me, I will always avoid. I want to emphasize that a collaborate is the most beneficial, the hardest, takes the longest, but it is the best. And most of us think that we're great collaborators. And I would urge you to, if you ever take the survey, ask some of the people you work with to rate you on that survey as well and tell you what they would say about you. And very often it's different. We think we're a collaborator, and they might think that we're really a competitor or something else. So those are the 5 of them, and you can see that they're all important, and there's a time. And I would also urge you to figure out, if you ever look at these more thoroughly, when do you do each of those? And is there a particular individual that it's better to do one of them than the other? Who is it that you want to avoid all the time, if anybody? Who is it that you think it's a good thing to sit down and have collaboration with? So also ask yourself, which conflict mode do you use most often? And you might want to rate yourself on those 5 and say, this is the one I use most often, this is the second, this is the third, and so forth. And which conflict mode would you like to learn to use more effectively? There's always one. I'd like to learn to avoid more often. I don't know about you, but sometimes I get in there and I just want to solve it, I want to work it out, and maybe the other person doesn't have the time, the interest, and really doesn't want to spend the time working it out. So remember, behavior breeds behavior. How you act in these situations under conflict is how the other person's going to act. So I want to expand this just a little bit. If you're in an educator role, if you're a patient educator in a formal role, that you're running classes for residents, for medical students, or even for other physicians, other attendings, think of these things very much whenever you can. However, I think you're going to come across this much more so when you're working one-on-one educating other people. And think about which mode is most appropriate with person X versus person Y. I want to give you another example of one of my clients who came to me and said that a surgeon, he was in the middle of an operation, a very challenging operation. I won't talk about what type of surgery it was, but there was a resident there, and in the middle of it, as a teaching device, he said to the resident, "Would you point to such and such an artery for me?" And the residents just stood there and didn't do anything. And he said again, "Would you please point to the such and such artery again, please?" And the resident didn't do anything. And he said it a third time, and he said he began to feel himself boil up. All of a sudden, inside, he was like, well, he called me up the next day and said, thank God we'd gone through this training, because I almost used the F word with this particular resident. This is not the first time that he's come, or maybe it was a she, I can't remember, I don't want to be biased against men. Not the first time that this resident has come and didn't know the answer. So I said, wait a minute, what did you do after the session with this person? Did you yell? Did you scream? What did you do? Well, I avoided, because I knew I was so boiled and so upset after surgery that I guess it was a she now that I think of it, that she didn't do what she was supposed to do and couldn't name that artery, which we'd been over many, many times. He said, I said, so tell me, what should you have used? What mode should you have used? He said, I should have sat down in collaboration. And I should have said, I noticed during surgery, I asked you this question, and you didn't know the answer, and I asked you again, and you still didn't know the answer, and I asked you again. So I gave the assignment, go back to this particular resident, and I want you to sit down, and I want you to have that conversation. The conflict is still there. Even though the conflict looks like it's disappeared, it's still there. That person probably doesn't ever want to be with you again in the OR, feels really embarrassed. It turned out that the person was afraid of this surgeon. This resident was afraid, had heard reputation about this particular person, and was so frozen. She knew what that artery was. The words didn't come out of her mouth. And the surgeon in this conversation, was able to educate her in terms of ways of how do you communicate with a surgeon that you're afraid of? How do you talk about the fact that maybe you are afraid of this person? And how do you come with the conclusion so that you can collaborate? or that you can compromise, or you can whatever, but not necessarily avoid. And so her silence was a means of avoidance. And when she talked about it, she realized that oftentimes she avoided more than she should have. Often, over and over again, she would avoid a situation, and that was really interfering with her learning. There was no question about that. So, am I okay still?
No,
I'm done? I'm over. Okay, so I was reading it the wrong way. So I guess I want to emphasize again, behavior breeds behavior. And you can only manage your own behavior. You cannot manage the other person's behavior. But if you're doing it the right way, the other person's going to follow suit, and you're going to see that the patient is going to be the beneficiary. Just one other thing that I want to say before I end, because this is something that someday I hope I can make a difference in the world of healthcare with. Administrators have to have compassion for physicians who are struggling with conflict management, with being frozen about interpersonal behaviors and anything else. When we can get it to go all the way up the chain, and everybody knows how to manage conflict, not just the people who are at the lower level or the middle level of it, I think we'll be able to transform healthcare in a better way, and we'll be able to make difference for patients in a positive way. So thank you.